really are finding that male breast cancer is not congruent with female breast cancer. Now that's actually important because we've been basing the treatment of male breast cancer for 50 years on the results of trials in women with breast cancer. And in terms of surgery and chemotherapy and hormone ablative therapy and even radiation, we found that men behave as postmenopausal women in terms of their tumor characteristics and response to therapy. The challenge is that as we move into the era of precision medicine and we base our treatments on targeting specific genetic lesions or specific pathways, men are different than women. And the more we unravel the genetics and the genomics and the proteomics of male breast cancer, it's a different disease than female breast cancer. What we've learned in the last couple of years is that the population-based incidence of male breast cancer is rising. In fact, it's up 20% in 5 years. Now, there are more men alive who've been on statins, who've avoided other diseases, and they live long enough to get male breast cancer. And so we've seen fully a 20% increase in the incidence of this disease in 5 years. So it's a slightly increasing problem, still about 1% of all breast cancer. But I think that we have to use some caution in the future as we begin to apply findings from targeted therapy studies in women. And we have to be cautious how we apply those to men. I think that across the country there still is a little bit of confusion about the genetics of solid tumors like breast cancer. And certainly in the case of breast cancer, none of the genes that are involved in the development of the disease are on sex chromosomes. BRCA1 is on 17, BRCA2 is on 13, and that means that the father's side of the family history is just as important as the mother's side. But it also means that having a male with breast cancer has genetic implications in terms of what someone's risk is. So I think that what's interesting is that men are not as referred as often for genetic counseling. They don't go as often, and even when they meet criteria, they're not tested as often. So I think we need to do a better job nationally of how we deal with men who are at increased genetic risk for this disease. Yeah, I mean, I think that already, if you look at tests like the 21 gene assay Oncotype DX, men have had their tumors studied using the 21 gene assay. And in fact, when we look at a frequency distribution plot of levels of recurrence score in men, it parallels very closely the recurrence score in women. And so we do think it's a reasonable way to extrapolate in that setting. But as we get more targeted and as we get more focused treatments, it's going to be harder to extrapolate from female to male breast cancer. We know that BRCA2 mutations in men increase not only the risk of invasive breast cancer, but the risk of prostate cancer and the risk of getting a worse prostate cancer than the average person gets. And so one of the questions that comes up is, how have these genes been passed from generation to generation to generation when in fact they threaten survival? And one explanation could be that there are actually fertility advantages that are imparted by having a BRCA mutation. And there are some studies now that sort of bear that out. So I think that's an interesting study. These genes are smart, and they have found a way to continue their livelihood through generations and generations and generations. I think this is going to be an interesting area of study.